Good afternoon. Thank you all for joining us today. Today, we're joined by Jonathan Pattenberg, who will be going over the impact of the new RHC reimbursement methodology, the impact overall, like what it looks like today and projecting out into the future. So with that said, I mentioned we do have a smaller group today. Please feel free. You can unmute your own lines. If you have questions, comments, please feel free to share those. I'll also be watching the chat to relay questions, comments, concerns, etc. So with that said, Jonathan, I'll turn it over to you.
Thanks, Laura. And I know we did this conversation probably about a month ago as a part of the CFO group. And today what we're going to be focusing on is mostly the same type of information. But as Laura had mentioned, we can go into much further detail. So if there are specific questions that I can answer or different things that we want to talk about, please don't hesitate to unmute yourself and ask those questions now. That is with the caveat that Laura had said that this is being recorded. So any question that you do ask will be forever enshrined as a part of this webinar. Now, the reason why we divided this up and decided to focus on it in not only the Critical Access Hospital CFO group, but also the RHC group, is because this is, again, one of those major changes that will impact reimbursements going forward. Now, it doesn't matter what type of rural health clinic you are, this will impact you in some way. For some organizations, it'll be positive. For some organizations, it will be negative. But nonetheless, this is something that will impact your reimbursements going forward. Now, what is interesting is as we've started to look at this different data and starting to analyze the different factors, we've come to realize that there are organizations and states that will definitely benefit from this change in the reimbursement methodology. However, on the inverse of that, there are also organizations and states that will be negatively impacted by this change in the reimbursement methodology. And it's important to understand that whether you are a rural health clinic or a critical access hospital that owns rural health clinics or a large PPS hospital that operates several rural health clinics, the change in this reimbursement methodology can and will impact your ability to continue to provide services in many communities, whereas your community and that provider is oftentimes a true safety net provider. And when we're talking about those different factors and really getting into those different nuances, the changes in these reimbursement methodologies can impact the ability to continue to sustain those services going forward. So as we talk through the information today, first what I'll do is again give a reimbursement overview. I'll be talking about exactly what has changed and how this will apply to organizations from a reimbursement methodology. Again, I just want to emphasize again that this is something that does and will impact every rural health clinic going forward in some approach. Then what we'll talk about second is really the specific impact on RHCs and hospitals and how that change in the reimbursement methodology will impact the state of Oklahoma going forward. Now, I wish I could say, do people think that Oklahoma would be better off or worse off in the long run because of this change in the reimbursement methodology? But since some of you may have attended the webinar about a month ago as a part of the CFO group, you probably would already know that answer. But again, nonetheless, we will talk about the nuances of that. And because we have a smaller group today, I'll go a little bit more into detail on specific strategies that we can focus on as a means to try to mitigate some of those changes coming down the road or that have already gone into effect. Again, because this went into effect last year on April 1st, 2021, where that new reimbursement methodology actually went into effect. So I know many of you have probably heard this before. What exactly has changed? On December 27th of 2020, the president signed the Consolidated Appropriations Act of 2021. And in that roughly 5,000 plus page bill, there were about 4 pages dedicated to change the reimbursement methodology for rural health clinics. Now, this not only changed the rate for some RHCs from an upper payment limit perspective, it also changed the methodology that some of those rural health clinics were experiencing. Now, before this change in the law, the way the reimbursement methodology really worked for our rural health clinics is If you were owned and operated by a hospital with fewer than 50 beds, and you were able to meet the different requirements as a provider-based RHC, you used to receive an uncapped cost-based reimbursement from Medicare, and in many states, Medicaid. Oklahoma is not one of those states where you get the full uncapped cost-based from Medicaid. But nonetheless, from a reimbursement perspective, from the Medicare side, if your cost went up to $200, Medicare would give you the $200. If it dropped to $180, you would get the $180 from that true uncapped cost-based reimbursement. And again, at the end of every year, you would file your Medicare cost report and get that reconciliation from the Medicare, the traditional Medicare plans. So this was a great benefit for many of those hospitals that owned and operated RHCs with that fewer than 50 bed threshold. Now, for our RHCs that were owned and operated by hospitals with 50 plus beds, or are truly independent RHCs, they were always subject to an upper payment limit. And last year, before the change in the law and the reimbursements, that was about $87. Now, I can truly say that that $87 rate was much lower than it should have been to sustain those type of services in a go-forward basis. And that really was much of the drive for why they looked at changing that reimbursement methodology, was because of the ability in a long-term perspective to continue to provide services for those independent RHCs as costs continue to increase at rates much higher than that RHC rate was increasing. It would have been impossible in the long term to sustain those independent RHCs without some type of change. Again, I don't think anybody on this webinar can say that their costs are only going up 1 or 2% a year. As many of you seen in the past couple of years, just with regard to traveling nurses or anybody else or supplies, our costs are going up well beyond a 1-2% increase. In fact, many of us are seeing increases in excess of 5-10% over the past couple of years. Now, when we look at the reimbursement methodology and what exactly has changed, on April 1st of 2021, that new reimbursement rate structure went into effect. Now, for our independent RHCs and our RHCs that are owned and operated by hospitals with greater than 50 beds, or 50 beds exactly, the upper payment limit increased from roughly that $87 rate up to $100 per visit. And again, it was still remaining as an upper payment limit. Now, each year thereafter, from 2021 through 2027, it's increasing by $13 as an upper payment limit. And in that last year, you would get a $12 increase up to $190. Now, the way the upper payment limit works is you get the lesser of your actual cost-based rate or the upper payment limit, always remembering that you get the lesser of the two. So again, if your upper payment limit is $100 and your cost-based rate is $80, you would get the $80 per visit from Medicare. If your actual cost-based rate is $120 and that upper payment limit is $100, you would get the $100. Always the lesser of the two numbers. Now, in addition to that, what the law also did was it changed the methodology for our provider-based rural health clinics owned and operated by hospitals with fewer than 50 beds. And again, included in that cohort was our critical access hospitals. Now, within that grouping and prior to that, as I mentioned earlier, those hospitals used to receive an uncapped cost-based reimbursement for those RHCs. Going forward, they will be subject to an upper payment limit. Now, depending upon when that clinic was established, will ultimately dictate what reimbursement rate those clinics are going to get going forward. And it's broken down between a grandfathered and a non-grandfathered provider-based RHC owned and operated by hospitals with fewer than 50 beds. And depending upon which one you are, will ultimately dictate, again, that rate that you receive. Now, if you are a provider-based rural health clinic owned and operated by a hospital with fewer than 50 beds, and you were established, meaning that you were actually an RHC by 12/31/2020, or you had applied to become an RHC by 12/31/2020, you would meet the grandfathering provision to operate as an RHC and to get that grandfathered RHC rate. Now, if you do qualify as a grandfathered RHC, your rate would be based on your 2020 reconciled cost report. And then that rate would be trended there forward based on the Medicare Economic Index. And for purposes, the Medicare Economic Index usually increases anywhere on average from, say, 1% to 2%. There have been years where it's been on either side of that, but most consistently it is between those two percentages. Now, if you were a rural health clinic that was established after 12/31/2020, or you applied to become a rural health clinic after that date, you will be subject to that new all-inclusive capped rate set at that national payment limit. Again, so those RHCs will be reimbursed and subject to the same cap as the independent RHCs and the RHCs owned and operated by hospitals with greater than 50 beds. So when we look at the differences up on the visual representation up here, and MedPAC did a great job of breaking this down, we can notice that there is a differentiation between a methodology change and just a change in the upper payment limit. So if we go across and again, look at our independent RHCs, they are still subject to an all-inclusive capped upper payment limit. The only thing that's changed for them is the value or the amount of that upper payment limit. Again, the $87 to $100 last year, $113 this year. But the methodology is exactly the same. If you are a provider-based RHC, and you are an RHC with a hospital with 50 plus beds, again, you are still subject to the exact same methodology. The only change is that that upper payment limit has increased and will increase greater in future years. For the RHCs that are owned and operated by hospitals with fewer than 50 beds, and again, established as provider-based RHCs, this is truly a methodology change. So not just a rate change, but a methodology change. Gone are the days of true uncapped cost-based reimbursement. Now you are subject to some form of an upper payment limit going forward. Now, as I mentioned a couple moments ago, if you were established after 12/31/20, or you applied after that date, you are subject to that same upper payment limit as the other RHCs. The grandfathered RHCs will have a rate that is set based on the 2020 cost-based rate for that clinic. Now, one thing I want to emphasize for our provider-based rural health clinics, the established rate will be trended forward each year, increased by the MEI. So let's say your rate is $200 this year, and it increased by 1%. Your upper payment limit will go up that 1%. Then the next year, your rate, say, goes up a 1% again. So each year, that rate from an upper payment limit for those grandfathered practices will continue to increase. Now, even if there is a year where your cost-based rate is less than that upper payment limit, it doesn't mean that future years, that rate will drop down to that cost-based rate and then trend forward from there. So there's not necessarily that direct correlation between what you're getting from an upper payment perspective and what your rate and reimbursements within a given year will actually be, because you always get the lesser of the two. Now, when we talk about these rates, it's very important for those provider-based RHCs that are getting that rate based on their 2020 cost report to ensure that they continue to meet those RHC program requirements going forward. Now, say you are an RHC owned and operated by a hospital with fewer than 50 beds, and you were to do a change of address, you can maintain that same rate that you were getting under that environment, so long as you continue to meet those RHC requirements. So what I mean by that is if you were to change your address and go to a different location, and that future location does not qualify as an RHC, you will jeopardize and lose that rate if that new future location does not meet the RHC requirements. Same thing also. Now, I realize we're in the middle of a ongoing pandemic where many of the waivers are still in effect. Now, if you were to go and you have your rate, let's just assume all waivers are gone and the pandemic is over, and your rate is set at $200 as an upper payment limit for a provider-based rural health clinic, and you end up going in excess of the 50-bed threshold to keep that cost-based rate, once you lose that rate, you cannot get it back. So very important that you ensure that you have the appropriate processes and steps in place to ensure that you protect that rate going forward. So it's almost like your necessary provider critical access hospitals that are established that are grandfathered from that perspective. You can maintain that in perpetuity and keep that rate, even though you don't meet the current rules around the reimbursement structure, so long as you meet the original requirements that were established when you got that rate and how it was prescribed within the law itself. Before I move on to the next section, I'm just going to pause for a second to see if there are any questions around the regulation, the reimbursement methodology, or any of those other factors before I jump into more directly the impact to the Oklahoma rural health clinics in particular. All right, not seeing any questions come in. I'm just going to assume that I gave it in so much detail that there are not any questions to answer. Next, what we're going to jump into is the impact to our Oklahoma rural health clinics. And again, this impacts every state differently from that perspective. And when we look at going forward from that perspective, even within a particular state, we have some organizations that are going to benefit from this change in the reimbursement methodology. We have some that are not. There is no one-size-fits-all approach, even when we're looking at one provider-based rural health clinic versus another. Again, the delivery model, your patient population, the cost, the reimbursements to your providers, the supplies. There are so many intangible items that go into those cost-based rates that it's nearly impossible to extrapolate across one clinic and compare to others and assume that they're going to have the exact same impact. But nonetheless, when we look at those different clinics, we can look at from the perspective of saying, how does this impact organizations going forward? Again, across those broad general themes. Now, looking at the provider of services file for 2020, in Oklahoma, at the end of 2020, there were roughly 100 rural health clinics across the state, with 15 of them being independent and the balance of them being hospital-based rural health clinics. Now, when I say hospital-based, what I mean by hospital-based RHCs are those that are owned and operated by a hospital. And the reason why I differentiate between hospital-based and provider-based is because from a regulation perspective, provider-based can include any of the hospital-based RHCs. But from a reimbursement perspective, our true PBRHCs that are owned by hospitals with fewer than 50 beds used to get that uncapped cost-based rate. So I like to differentiate between the two to ensure that when we talk, we're talking apples to apples and not blending because of those different reimbursement methodologies. Now, when we look at 2020, there were 13 new RHCs established. And if we look, the overwhelming majority of those, again, were those true PBRHCs, and in this context of hospitals with fewer than 50 beds, so qualifying for that uncapped cost-based rate. Now, if they did not change the law and pass HR 1868, all of those RHCs, including those 12 RHCs established in 2020, would have been subject to that new $100 upper payment limit last year in 2021. Now, because that law ended up passing and got signed, those 12 RHCs established that were provider based in 2020 qualified as grandfathered RHCs. And again, this could be a huge difference in reimbursements between grandfathered and say getting $175 and non-grandfathered getting $100 as an upper payment limit. Now, when we look across in 2020, there were 25 critical access hospitals that owned and operated 52 rural health clinics. Now, the reason why I draw attention to those critical access hospitals is because critical access hospitals, again, oftentimes are a safety net provider. And under the Medicare program, they get cost-based reimbursement as a critical access hospital from Medicare services. Again, those that qualify under the critical access hospital program. Now, what has happened is because of the change in the law, these programs, these RHCs have gone from a cost-based program for these critical access hospitals to an upper payment limit program. And again, the reason why I emphasize this is because of how the cost report works for our critical access hospitals. And what ends up happening is that when we have critical access hospitals that own and operate rural health clinics, they pull down a segment of administrative cost and other overhead expenses to those critical access hospitals that are now non-cost based. So the reason why I bring this up is because with that program in the past, you were moving from one cost-based program as a critical access hospital to another cost-based program as a rural health clinic. That is no longer the case. You are now moving from a cost-based program as a critical access hospital to a non-cost-based program, or at least subject to an upper payment limit program as a rural health clinic. And what this means is by being subject to that upper payment limit, any year where your cost increases at a greater rate than that upper payment limit, you will not recover those reimbursements from Medicare. Again, you will lose out on those reimbursements. So what I mean by that is if your cost goes up 5% and the rate goes up 2% from an upper payment limit, you will lose out on that 3% reimbursements from that perspective. Now, if we look across the more specific distribution of the RHCs and look at the state as a whole, the state of Oklahoma saw roughly 159% increase in the rural health clinics between 2015 and 2020. And when we look across, we can actually see that the majority, in fact, almost all of the increase is attributed to our true PBRHCs. And they've seen an increase going from roughly 30 clinics up to 80 clinics. For our upper payment limit subject clinics, we increased on the hospital-based 50 plus beds from 2 to 4, and the independents went from 18 down to 15. But nonetheless, the overwhelming majority are those provider-based rural health clinics. Now, some of you may be looking at the numbers and saying, why are there some years where their clinic number is lower than the cost report number? The reason for that is because we end up running the POS file as of year end. And any clinic that was terminated within a given year, we remove that off the list. So it's looking at clinics at year end. The cost reports, we ended up looking at any cost report that was filed within a given year. So if you end up terminating your clinic, you would have had to file your closing cost report for that RHC, which is why in some years you have a cost report, but the clinic count number is lower. Now, on the other side of that, if the cost report number is lower than the clinic number, for instance, the cost based in 2020, there were 82 clinics and only 66 cost reports. That is because rural health clinics had the ability to consolidate their cost reports for cost reporting purposes. And instead of filing 10 cost reports, you could file a single consolidated cost report for the collective of all of those clinics. And again, there were certain advantages and distinctions for why organizations may look to do this. And some of those come down to the ability to meet productivity threshold requirements, the ability to blend cost across a collective of clinics, and a whole bunch of other perspectives and reasons as to why to consolidate the cost reports. Now, one thing I want to emphasize is there are some restrictions now about the ability to consolidate cost reports, particularly for new clinics versus the old grandfathered clinics, because of the provisions applicable and the differences in reimbursements. So again, if you are looking at consolidating cost reports, I would definitely recommend you reach out to your cost report preparer to ensure that if you are looking at consolidating your cost report, you do so in a way that meets current Medicare cost reporting requirements. Again, don't want any of you submitting a cost report that doesn't meet the requirements that could jeopardize your program and your reimbursements. Now, when we look across all of the RHCs across the state, again, we can see that there are a number of rural health clinics and the visits vary greatly across those different clinics. And we can see that on the very high end, we have some clinics that are about 85,000 visits. And on the low end, we have a couple hundred. Now, I can emphasize also that these tables coming up are all based on cost report data. So in the event that you see like this one with 85,000 visits, that is not a single clinic. That is a collective of multiple RHCs that filed a single RHC cost report, which is why there are 85,000 visits. I don't think I know of a single RHC across the country that has 85,000 visits in a single location RHC. That might be a pretty robust area. I don't know if they'd meet the rural requirements if they had that at a single true location. But nonetheless, we can see again, the visits are all over the place. But again, the overwhelming majority are under those provider-based rural health clinics. And again, just because there are more PDRHCs in Oklahoma than the independents. Now, when we look at this table, we can see that the orange colored lines or the orange bar charts are the non-PDRHCs, again, those independents and the hospital-based 50 plus beds. And the blue are our PDRHCs. And this is holding consistent throughout the rest of the presentation. Now, when we look at the average cost per visit across those rural health clinics, this is actually an interesting slide that provides a little bit of optics into several areas. Now, as I mentioned earlier, we took every clinic's cost report and calculated across the impact to each one of those RHCs, and then ended up consolidating all of that information to calculate the impact on the state as a whole. Now, when we look at the total cost for our PDRHCs versus non-PDRHCs, there's about $119 million in cost for our PDRHCs and just under $15 million for our non-PDRHCs. Now, as I mentioned earlier, when we look at our rural health clinics, our cost-based rate is based on using the actual visits or the adjusted visits. And the adjusted visits takes into account the minimum productivity threshold. So when we look at this table up here, when we look at the visits, the actual visits for our provider-based rural health clinics was about $513,000 or 513,000 visits. And the cost per visit, taking the cost divided by those visits, came out to about $232 a visit. The adjusted visits, which again adds up all of those different FTEs and multiplies it by the minimum productivity thresholds, that 4,200 per one FTE physician and the 2,100 per one FTE APP, it's definitely a tongue twister. We came up with 544,000 visits. Now, again, because you use the greater of those two numbers to determine your reimbursements, using the adjusted visits, we came up with an adjusted cost per visit of about $219. So the failure of all of those provider-based rural health clinics to achieve that minimum productivity threshold means the state lost out on average of about $13 per visit across those 500,000 visits if it was across all, but across the Medicare business. The non-PBRHCs, even though they're not cost-based, because the increase in the upper payment limit going forward, it's important to look at that from a productivity threshold also. Now, those practices had about 99,000 actual visits. Their adjusted visits was about 103,000 visits. So they would have lost out on about $7 per visit, again, because of not meeting that minimum productivity threshold. So again, definitely an opportunity for the clinics to look at productivity, to look at throughput, and all of those different factors. Now, one thing I want to emphasize also is because this was based on 2020 cost report data, where 2020 was your cost-based year starting point for those PBRHCs from a grandfathering provision, you have locked in a lower rate going forward that is not starting truly at your cost-based rate, meaning that you are already behind from a margin perspective going forward. So you'll have to increase visits and control costs just to get back to a break-even perspective. Then in future years, control that inflation cost to what less than the MEI is going forward. Now, one thing I do want to emphasize also is in 2020 and 21, our rural health clinics could apply for a waiver in the productivity thresholds. Medicare had came out and said that because of the COVID pandemic that was impacting the ability to provide services, the access to staff, and all of those different factors, you could apply for a waiver to that productivity threshold. Now, the fact that I pulled all of the cost reports and you were under on an average across the state by about $13, this emphasizes that there were many clinics that did not go in for that minimum productivity threshold for the waiver. And again, this is an opportunity that we should have looked at in the past. Again, I would reach out to your cost report preparer to see if that's something you can still do in light of not going forth and doing that. What this does is, again, it just puts a chart in perspective of all of the different costs per visit. Now you're looking up there and you're saying, wow, there's a clinic up there with like $1,175 rate. What is that? This was actually a new rural health clinic. And as many of you have realized, when you started a new rural health clinic, that first year you can have cost, which is greatly in excess of what your true future rate is going to be. But from that perspective, we can look across all of the RHCs and see that those cost-based rates or those RHC costs per visit is around, on average, I would say $235, significantly below $250 across the collective. And this is important when we talk about the methodology and the approach going forward. Now, let's put some dollar figures onto what did the missing of the productivity threshold do in the way of lost reimbursements from a Medicare perspective. Now, again, we only looked at traditional Medicare because that's the only data we can get across all of the clinics. We don't have access to the Medicare Advantage, the Medicaid, and all of that different stuff. Now, again, looking at Medicare reimbursements for the PBRHCs, we received about $33 million in reimbursements, and there were 147,000 visits. So again, the reimbursement per visit was about $222. But again, the cost per visit was about $233. So the state, for those PBRHCs, lost out on about $1.6 million in reimbursements due to not achieving that minimum productivity threshold. So again, definitely an opportunity to look at those from that perspective. Now, when we talk about the FTEs, again, it's not purely just missing that objective going forward. There are many reasons that could cause us to miss the FTE calculation. Maybe we're overstating the FTEs and not carving out vacation and sick and administrative time. Maybe we're counting certain providers that aren't actually in the clinic. Again, I've seen a whole list across different practices that could lead to an overstatement of those FTEs. Again, taking all of those things into different account. For our non-PBRHCs, That one really looks more at the impact of having a cost-based or a capped upper payment limit, again, the lesser of the cost or the UPL, of $86 roughly per visit, but the actual cost being closer to $149. So again, those practices lost out on about $2 million because of that upper payment limit. Now, when we look at the average reimbursement across each one of those clinics, again, this is the average reimbursement received, not the average cost. We can see that, again, the reimbursement rates are all over the board. I know you saw in that prior chart where that one clinic had an about $1,100 rate, and we could see after we adjust for FTEs and all the different factors, their actual reimbursement came in at about $500 per visit. But nonetheless, we could see that the rate on the overwhelming majority for the PBRHCs is between $200 and $300. Now, the orange bars on the chart, again, they were getting roughly that $86 in reimbursement, so they're pretty consistent all the way across the board. Now, there are minor fluctuations in that bar chart for the non-PBRHCs, and the reason for that is because if they span multiple calendar years, the rate is applied based on a calendar year perspective, meaning in one year they may have received $86, the next year $87 as an upper payment limit, which is why there's slight variations across those different practices. Now, the next slide gets more into what does this mean for the state of Oklahoma. Now, again, what we ended up looking at is we pulled every cost report for every rural health clinic across the state. And we went all the way back to 2015. And we wanted to look at the average annual cost increase across the PBRHCs and those non-PBRHCs. Now, first looking at those provider-based, cost-based rural health clinics, in 2015, they had an average cost per visit of about $165. Again, $35 million in cost, 200,000 visits, $165 roughly in cost. Now, because we've seen, again, that significant increase, I think I mentioned it was like 100 and whatever, 50%, that those have gone up. We've seen a drastic increase in the cost associated, but also the visits. Now, the average cost or the total cost increased from 35 million to 119, and the actual visits increased from 200 to 500. The cost-based rate increased from $165 up to $232. So year over year, from an annualized perspective, the Oklahoma rural health clinics have seen about a 7% increase as PBRHCs. Now, the reason why I'm emphasizing this numbers is, again, because for our grandfathered RHCs, you get your lesser of the upper payment limit or your rate that's increased based on the MEI there forward. So again, in the perspective where the MEI this past year was like a 1.5%, and the average cost increase was 7%, each year you would lose out on the difference between those two numbers from a reimbursement perspective. Now, for our non-PBRHCs, they started at about $7.7 million in cost and increased to about $14 million. The visits went from about 74,000 to 99,000. However, their average cost per visit went from $104 to $148. So again, similar to the PBRHCs, their average cost per year, if we looked at from an annualizing perspective, increased 7.39%. So again, in excess of 7%. So what this next table looks at is says, okay, if those practices continued going forward at an annual increase and the costs were continuing to increase at a certain percentage, what would that do from a perspective of reimbursements? Now, first looking at our PBRHCs, we started at $222 in 2020. And again, because we assume that these clinics will do things to create operational efficiencies and performance improvement, increase visits, whatever else it may be, we ended up using a 3% increase across the PBRHCs and the non-PBRHCs. So if this rate increased 3% every year from a cost perspective, but the MEI was only 1.4%, that means in 2021, the PBRHCs would lose out on about $3.60, trending forward all the way to 2028. Again, a 3% increase every year, matched to a 1.4. By 2028, they're going to lose out on about $33 per visit. So very important that there is that compounding effect from a loss perspective. For our non-PBRHCs, again, start at $134, compare that to $86 in 2020, increasing by the same 3%, their cost per visit increased to $171, whereas the capped rate increased to about $96. Now, if we look at the table up here also, we can see that it's $100 is green, $113, $26, and so forth. Then all of a sudden in 2026, the green box ends up being $161. And again, the reason for that is RHCs, you always receive the lesser of the cost-based rate or the upper payment limit. And because the actual cost-based rate in 2026 is less than that upper payment limit, that's where you use the cost-based rate from that perspective. Now, I do want to emphasize again that this just consolidates all the information. When we did all the analysis and the calculations, we calculated the net impact across each individual clinic going forward. So this ends up providing a more realistic approach or perspective to the impact on those clinics because of the fact that we modeled across each one of those clinics. So what does this mean for the state of Oklahoma? And again, this was based on a 3% annual increase. If it was 5% in an annual cost increase, the situation would be worse than what is up here on the screen. If it was the 7%, it would be even worse than that. So again, this looks at a 3% compared to the 1.4% MEI. Now, in 2020, there were 147,000 Medicare visits for PBRHCs and 34,000 visits for the non-PBRHCs. The old rate was $229 for the PBRHCs. The new rate, again, because we're increasing it based on the MEI, which was about 1.4%, those RHCs would lose out, the PBRHCs, on about $500,000 in reimbursements. The new RHCs, again, those non-PBRHCs, their rate would go from about $87 up to $99. They're going to gain about $400,000 in reimbursement. However, again, because we're looking at the collective to the state, the 500,000 negative and the 400,000 gain means that the state as a whole from this new reimbursement methodology would lose out on about $128,000 in 2021. Now, again, this maintains a status quo. If there are ways to create operational efficiencies and improve performance and all those different factors, this may not be as bad, but again, it's to highlight a status quo environment. Now, if we trend this forward all the way through 2021 and say, let's keep increasing costs by 3%, the rate would be up to $281. Increasing the new methodology, the 1.4%, we'd be at $248. Those PBRHCs as a collective would lose out on almost $5 million in reimbursements. Now, one thing I do want to emphasize again is this is not a true loss from a financial performance perspective like a P&L. This is comparing the net differential in reimbursements between the old methodology and the new. So I just wanted to highlight that perspective. Now for our non-PBRHCs, again, they're going to increase from about 400,000. And in 2028, their rate is going to go up to $170 almost. So those non-PBRHCs are going to gain almost $2.5 million in reimbursements. Nonetheless, the collective of the state as a whole, if all those clinics were to experience a year-over-year 3% increase, the state as a whole is going to lose out on about $2.4 million just from traditional Medicare. Again, whether or not you have Medicare Advantage plans and factoring all that in, that would also impact these numbers from that perspective. Now, when we talk again, what are different ways that we can mitigate the impact of some of this? Definitely need to look at from the perspective of there's really two major ways. We can try to cut cost. And again, that only works to a certain extent, particularly for rural providers where many of you are operating at minimum productivity thresholds. The other end is to try to increase volumes. And because many of our smaller facilities, particularly rural health clinics, have significant fixed cost versus variable cost, increasing our cost or increasing our visits will only increase the cost at a minor amount. So we will continue to dilute down those rates as we go forward. Looking at our FTEs, are our FTE calculations correct? All of those different factors. Are we appropriately aligning costs within the appropriate departments if we're hospital-based? Again, a whole countless number of ways that we can look at trying to impact those reimbursements going forward. So I know there's about 10 minutes left. And what I wanted to do is open it up for any questions relative to the topics we've discussed, any other maybe nagging topics that are bothering you around rural health clinics, and really just afford you the opportunity to ask any questions you may have. So I'm going to open it up again to questions. Please don't hesitate to ask anything you may have.
Jonathan, this is Laura. I'm not seeing anything in the chat either.
All right, well, not seeing any questions. Oh, somebody unmuted. Go ahead, Doug.
I do have one question. I did hear some discussion a while back about the potential for some of these caps going away. Is there any possibility of that?
Yeah, that's actually a great question. There have been two bills that have been submitted so far. The first one was actually originally sponsored by Congressperson Sewell out of Alabama. And that one is, I believe it's up to 12 or 13 co-sponsors right now. And that looks at requiring provider-based rural health clinics to submit certain quality data, things along like PCMH type approach and quality and to track those rural health clinics. And in exchange for that quality data, those PBRHCs would go back to getting the uncapped cost-based reimbursement. That is a standalone bill. In addition to that, another bill that was also introduced was the Save Rural Hospitals Act. And that is a much broader bill that addresses many of the issues within the healthcare environment. And within that bill, the primary difference between the two is in that bill, it does allow the PBRHCs to go back to an uncapped cost-based rate. However, those clinics would be able to elect to participate in the uncapped, in the quality data submission in exchange for the uncapped, whereas the other bill would require it. Both are, before Congress. Hopefully one of them will pass. I haven't seen anything pass yet, but I do. I mean, for all of our PBRHCs, I do emphasize and encourage you to reach out to your congressional delegates or representatives because, for instance, you can see the negative impact that this is going to have just in an Oklahoma perspective. And I've seen some states where it's upwards of like a $20 million loss when you get out to 2028. So there are bills submitted. I would definitely reach out if you want to encourage those for passing.
Are there any?
So not seeing any other questions, I'm going to turn it back over to Laura. We do have our next webinar series coming up for our rural health clinics. But again, I will turn it over to Laura to wrap us up. And thank you very much for attending today.
Yes, thank you, Jonathan. I was just looking at my calendar. Our next one is scheduled for May 26th at noon, and we'll be talking about revenue cycle best practices. So thank you all for your time, and everyone have a great week or great weekend. Thank you.
Thank you.